is Dr. Susan Kafle, and today I'll be discussing about the disorders of conjugate horizontal gaze. In this topic, I'll be talking about the lesions of the frontal eye field area, the paramedian pontine reticular formation, and also about the internuclear ophthalmoplegia. Now let's look at this photo. We know that the eyes are supplied by different extraocular muscles. The extraocular muscles that are responsible for conjugate horizontal gaze are the lateral rectus muscle and the medial rectus muscle. If we have to look towards the right side, the lateral rectus of the right eye needs to be stimulated and the medial rectus of the left eye needs to be stimulated. So we'll discuss how this stimulation happens at the same time. In the cerebral cortex, we have an area called the frontal eye field area. I will take an example where we want to look towards the right side. So to look towards the right side, the frontal eye field area on the left side fires and the neurons cross over to the other side to reach the paramedian pontine reticular formation, which I will refer to as PPRF from now on. So the left frontal eye field area provides the supply to the PPRF on the right side. From the PPRF, a neuron arises which supplies the sixth cranial nerve nuclei or the abducens nerve nuclei on the same side, that is the right side, and then via the sixth cranial nerve, the lateral rectus of the same side gets stimulated. Now, from the sixth cranial nerve nuclei, another fiber arises called the medial longitudinal fasciculus, which crosses over and supplies to the third cranial nerve nuclei of the other side, that is the left side. And from the third cranial nerve nuclei, the third cranial nerve rises and then that supplies the medial rectus of the left eye. And so when PPRF is stimulated, we have simultaneous stimulation of the sixth cranial nerve nuclei and the third cranial nerve nuclei at the same time, and hence the eyes look towards the right side. So likewise, when we want to look towards the left side, the left frontal eye field area would fire and then reach the paramedial pontine reticular formation of the left side, which then supplies to sixth cranial nerve and then the third cranial nerve of the opposite side. All right. Now, what would happen when we have a lesion in the frontal eye field area or the PPRF? So we just discussed about an axis in relation to the rightward gaze. So if the left frontal eye field area is damaged or the right sided PPRF is damaged, then we can look normally towards the left side, but we cannot look towards the right side. So there will be an absent rightward conjugate gaze, as you can figure out from this picture itself. What about a lesion in the medial longitudinal fasciculus? If we have a lesion in the medial longitudinal fasciculus, the PPRF has already received a signal for the contralateral gaze or the for example, you want to look towards the right side, frontal eye field area has already fired from the left side. It has already reached the PPRF. The PPRF has already supplied the sixth cranial nerve nuclei, and the lateral rectus of the right eye would get stimulated. But the medial rectus of the opposite eye needs to get stimulated via the medial longitudinal fasciculus. So if we have a lesion in the medial longitudinal fasciculus, leftward gaze is normal, but when we want to look towards the right side, there will be an adduction failure in the left eye because the medial rectus of the left eye would not receive its supply from the third cranial nerve nuclei because it would not get stimulated as we have a lesion here in the MLF. So So imagine a condition where we want to look at the right side. The frontal eye field area has already fired, PPRF is already stimulated, and the lateral rectus on the right eye is already stimulated. But the left eye cannot follow the right eye towards the right side. So the left eye sits at the center, the right eye tries to look in the rightward direction. So there will be an imbalance in the gaze of the two eyes. Our brain tries to correct this. What happens is this eye, the right eye, although it tries to look towards the right side, the brain autocorrects it and brings it towards the center. So there will be a nystagmus of the opposite eye. The nystagmus is a corrective step so that there will be no diplopia or double vision. All right, so if we understand this concept, then figuring out any conjugate case palsy becomes easier. So, as we discussed, the frontal eye field area, it is responsible for the gaze towards the opposite side. So the left frontal eye field area is responsible for rightward gaze, and if we lose the left frontal eye field area, then the eyes would prefer to look towards the left side itself because the right-sided gaze will not be there. So there will be gaze preference to the ipsilateral side. It is frequently tested with relation to the MCA territory stroke because if we have an MCA territory stroke of say left side, then we'll lose the left frontal eye field area. All right, this is a very high yield concept. Now, if we have a lesion in the paramedian pontine reticular formation, there will be gaze preference towards the opposite side of the lesion because the PPRF of the right side is trying to stimulate the lateral rectus of the right side itself. So it is trying to look towards the side that it is located in. Right PPRF wants to look towards the right side. Left PPRF wants to look towards the left side. So if we have a right PPRF lesion, we won't be able to see towards the right side. So the gaze will be shifted towards the left side. All right. You have to know this difference. You have to understand this pathway in order to localize the lesions when you're asked in the exam. And PPRF lesion is frequently tested in relation to the pontine strokes. So now let's discuss about the internuclear ophthalmoplegia, which is due to a lesion in the medial longitudinal fasciculus. The medial longitudinal fasciculus arises after the PPRF. So when we want to look towards the right side, for example, then the left frontal eye field area would fire. It would reach the PPRF, then it would reach the sixth cranial nerve nuclei. It would stimulate the lateral rectus of the same side, and then it would want to stimulate the medial rectus of the opposite side via providing the third cranial nerve nuclei with the fibers through medial longitudinal fasciculus, but it has a lesion, so the medial rectus would not get stimulated on the left side. So what would happen is left MLF lesion would lead to failure of adduction of the left medial rectus. So there will be ipsilateral adduction failure, even though the lateral rectus would try to take this eye towards the right side. The brain would tell the eyes to bring the gaze back towards the center, so that would lead to the nystagmus of the opposite eye. So the internuclear ophthalmoplegia occurs when attempting a contralateral gaze. If left MLF is lesioned, when we try to attempt a rightward gaze, then only will be seeing these manifestations. We will not be seeing these manifestations when we attempt a leftward gaze because the leftward gaze occurs through a contralateral pathway. If you can understand this pathway, then you will be able to figure this out. So I highly suggest that you remember how the conjugate gaze occurs. Internuclear ophthalmoplegia, there are several causes of it, but the most tested in the exam is in relation to either the multiple sclerosis or the stroke in the medial side of the brainstem. Most of the times in multiple sclerosis, the INO would be bilateral. If it is ischemic stroke, then the question stem may mention signs and symptoms of unilateral INO. That's it for this video, guys. This is a very short topic. I hope you get the pathway, and I hope that you can solve the questions related to the disorders of the conjugate case easily. Thank you so much.